And then we also want to just share with everyone. Should I share my screen, Judith, for right now, or do you want to keep the agenda up? I can share a few slides. If not, I can just read them off too, whatever's easy.
Go ahead and
I have shared. I was just chatting away with absolutely no sound. That's what we do in 2020.
Go ahead and post them, right? And we will. If they want the agenda, it's in chat, right? So we'll move on to the next slide.
It is. So Claudia's going to put hers up now.
Yeah. These are a few of our slides that we like to share with the group. Let's see. All right, there we go. All right. So this is the mission for Psub, and I can just go briefly over this or just read it. Let's go ahead and start. So really the mission of Psub is to work with the mayor / police commissioner, the Portland Police Bureau, and Portland's diverse constitutes to solicitate and exchange information between the community and Portland Police Bureau to achieve the desired outcomes, equitable policing, which exceeds constitutional requirements, and meaningful community engagement with and trust in PPP. Sorry, I lost there we go. So these are a few of the Psub values, and all this info is also on the Psub website. And if you need help, I can also guide you to where these slides can be found on the Psub website. I would just read off maybe like 4 of the values, and I think these are ones that actually really stand out to me, and I'm happy to also share others. So some of the values are trust, open-mindedness, listen with intent, and then effective communication. And so these are the most important housekeeping rules during Zoom. We just ask folks to keep the sound off unless you're talking. And in the participation box, use the raising hand and turn off your video if you're not a presenter. Use the chat box to communicate. If you have any needs to staff as well, you can always message us privately. And we just always look out for Zoom bombing during our Zoom meetings as well. It's really important for us. So I'm always on the constant lookout, making sure we don't get bombed on Zoom. And most of our meetings have now moved over to recording. So I will edit this dot, but ultimately we've just started to record all Psub meetings public for members and the public to later on YouTube. And then we just ask for everyone to hold their questions and kind of try not to flood the chat with too many questions before the Q&A of the meeting or the public comment period of the meeting. And then our last slide.
Claudia, oops, sorry.
Go ahead, Judith.
I just wanted clarification because it said turn your video off if you're not presenting, but I think what we mean is mute your microphone, right?
Yes. Yeah. Actually, okay. Yeah, that's exactly so.
Awesome, thank you.
No problem. I could go ahead and edit. I'll edit these slides a little bit. But yeah, and then this is the general email that you can reach Psub members at. I always go ahead and forward those emails over to the members. And that is Theolata, our project director's number and email. And if anyone wants to contact a Psub member directly, I can always give you guys their email, and it is also on the contact list tab of the Psub website as well if you want to just reach out to a member individually. But thank you guys for listening to me, and I will just go ahead and pass it over to Amy.
Okay, well, thank you, Claudia, for that wonderful information. Can we flip back to a regular screen? Okay, super. Thank you all. Basically, the reason why we're gathered here tonight is in bringing the conversations to the table is that we have a wonderful system in our community called the Behavioral Health Unit, which does an enormous amount of work with folks who are in crisis or semi in crisis. And with the continued educational series that we've been doing through the subcommittee, I just felt it was really important to hear from folks who are actually doing on the ground work, like those responding to calls, those that are involved in the calls, so that the community can get a chance to hear and see and learn what it really looks like when somebody responds to, or possibly when somebody responds to a call. So that's the reason we're all gathered tonight and what the messaging is going to be all about. It's on the agenda. But the first thing I'd like to start out with is introductions. And so my name is Amy Anderson, and I'm the chair of the Behavioral Health Subcommittee. And if other PCCEP members could introduce themselves first, that probably would be good. And I can't see everyone, so I'm going to need some help here. Full screen. Okay, so who would like to go first?
Yeah, I can. Can you hear me okay?
Hmm?
Can you hear me okay?
Yes.
Okay, hello everyone, Taji Chestnut. I use he, him pronouns. I am one of the co-chairs of PCCEP. And yeah, thank you so much. Oh, I'm also in the youth subcommittee as well. So thank you so much for having me.
Good evening, everyone. This is Marcia Perez. I am the chair of the Racial Equity Subcommittee, and I'm happy to be here tonight.
Thank you.
Hi, everyone. My name is Kia Myers-Dugan, and I am also a PCCEP member.
Welcome. Thanks for coming.
Amy, would you like me to go down the list?
Yes, please, because I don't have that screen view. Yeah.
Allison? Would you like to introduce yourself? No pressure also if you're not interested. Okay. And if I missed you because you didn't get your mute, I'll come back. Amber?
Hi, I'm Amber Christensen, and I'm a local activist. That's it.
Good to have you here.
Thank you.
And Casper? Okay, she might also not be right near her phone device. Barbara?
Judith, she put something in the chat.
Oh, I'm sorry.
Okay.
Oh, no mic tonight. Thank you so much. She said she's Ann Casper, Masters of Arts, PSS, helped shape the original ECIT team and training. Great to see the team here. So glad to see this service continue all of these years. No mic tonight. Warm line operator, please. Okay. Barbara, did you go?
Okay, I'm Barbara Bushinsky, Portland Cop Watch, she, her.
Thanks for being here. Billy?
I'm Billy Kemmer. I'm with the Behavioral Health Unit, Portland Police.
Welcome.
Thank you.
Thanks for being here. Casey?
Absolutely.
Good evening. I'm Casey Hetman. I'm the lieutenant that oversees the Behavioral Health Unit at the Portland Police Bureau.
Glad you could join us.
Good to see you. Cindy?
She's the one that works for Cascadia that I've been wanting to meet.
Cindy Hackett.
My name is Cindy Hackett. I am a mental health clinician with the Police Bureau's Behavioral Health Unit.
Thank you for being here, Jan.
Hi, I'm Jan Friedman. I'm with Disability Rights Oregon, also the Mental Health Alliance, and on the Behavioral Health Unit Advisory Committee too.
Thank you. Jared?
I think she's the one. Hi, I'm Jared Hager. I'm with the Department of Justice. I'm here in my role as the monitor of the settlement agreement between the United States and the city of Portland. I appreciate you having me here, and thanks, Amy, for putting on a good educational piece.
Jiro? I hope I pronounced that correctly.
Yes, perfectly. Yes, my name is Jiro. I'm a process work facilitator. I'm kind of alternative service provider.
Welcome.
Great to have you, Jiro.
Yes.
Lindsay? Is Lindsay here? Okay, Maxine.
Hi, it's Maxine Bernstein. I'm a reporter for the Oregonian.
Great, thank you. Mary Claire.
Good evening. It's Mary Claire Buckley. I work at the Portland Police Bureau doing the
after 3 days.
DOJ compliance work.
Great, thank you. Patrick?
Hi, Patrick from Mental Health Alliance.
Glad you're here. Rochelle?
Hi, I'm a psychologist and I'm with the Mental Health Alliance also.
Thanks, good to see you, Rochelle. And Ruthie?
Hi, I'm Ruthie Benjamin, a community member and also on the Behavioral Health Advisory Council.
Welcome. Sarah?
Hi, my name is Sarah Tall. I'm a clinician with the Behavioral Health Unit.
Great. Sarah, I think Stephen B.
Hi, my name's Stephen Brock. I'm a community member. I'm just here to learn and be supportive.
Thank you. Yesenia? Okay, Barb? Barb doesn't look like she has. There she is.
It just takes me a minute because I'm running the mouse.
I'm next to Amy. I'm her peer for all of this, and I've been at all of these behavioral health subcommittee meetings, and I am a Psub groupie at this point. I'm so glad everyone's here.
Thank you, Barb. Okay, thank you everyone for introducing yourselves. As you notice on the agenda, I set aside a little time for an icebreaker, but given that I really am eager to hear from the presenters, I'm just going to do a short little ask, and that is the subject right now in my world is about self-care. And with COVID and everything going on, a lot of people are at home and some are working from home. And so my question was going to be, what are you as individuals doing to assure that you are taking care of yourself or self-care during this time when we're all kind of extra strained? So I'm not going to ask everyone, but if if anyone wants to volunteer, mine is definitely getting acupuncture. That right now for me has been a major help, and getting my nails done at the beauty salon. That's my self-care that I do monthly, weekly. So if anyone else would be interested in sharing, like maybe, how about 5 of the professional folks who work in the industry? What do you do for self-care? Don't everyone speak up at once. If you force me to call on you, I will. Okay, I'm going to call on Casey. What are you doing for self-care during this time period?
Yeah, I'm finding time and excuses to go outside and do stuff. I like walking and running, but thankfully I've got a number of trees on my property that drop a lot of leaves, so it's forcing me to be outside and doing that, which I think doubles as self-care, but then also taking care of yard work. But the fresh air and sun's been nice.
Absolutely, self-care. I know about the leaves. How about you, Billy? We haven't seen you much. What are you doing these days for self-care?
So I'm home. I have 2 little girls at home. So we have spent the last 6 months constantly rearranging our house to find like the most efficient setup. So I spend most of my off time reorganizing rooms and switching rooms, and then reorganizing the room that we just switched. That's pretty much.
That's good.
It keeps me in check. Yeah.
I'm going to ask Jared, what do you do? What are you doing for self-care during this time period?
Oh, I guess that assumes I'm taking care of myself. I will say I'm an avid games player and puzzler. I do the New York Times crossword puzzle every day, and I play a lot of chess online, and chess relaxes me, helps keep me focused on different things. Thanks for the question.
Yeah. Okay. Well, if there's anyone else who'd like to ask, I don't want to leave people out, but I just want to get some ideas. And I really care about what everybody's doing so we all stay healthy and, you know, mentally challenged and physically worked out. And that kind of was my little icebreaker for today. I probably should have done it during introductions, but I don't like putting people on the spot. So we will go ahead now and move into our educational piece. Casey, were you going to lead the group in the conversation, or who
Sure,
should?
I can. So as we've discussed in previous PSCEP Behavioral Health Subcommittee meetings, we've tried to educate the group about the structure of the Behavioral Health Unit within the Police Bureau, what that looks like. And to that end, we wanted to bring one of our behavioral health response teams. Those are our co-responder teams comprised of an officer, a mental health clinician, to the group so they can provide some firsthand knowledge to you guys, their experience, what a normal day looks like for them, the different efforts that they lead in trying to connect folks with appropriate services, and maybe some case studies or examples of what that looks like in true life. And so today, to help facilitate that conversation, we have Officer Billy Kemmer. He's one of the officers in BHU. And then we also have clinician Sarah Attal. And we're lucky enough to have Cindy Hackett as well, who's another one of our clinicians on one of our teams. We currently have 5 co-responder teams. And so, yeah, we've got some representatives of those. Billy and Sarah are assigned our homeless and houseless caseload. And so that's predominantly the population that they're currently working with, but they have some experience working other types of cases and with other clients as well. So I think the thought was, instead of having more of a canned presentation, we would just kind of throw it to them, let them introduce themselves and really kind of talk about the work that they're doing, and then kind of have more of an organic conversation around things that interest you, or if you guys have any questions, we can go through that and have it be more informal, kind of like a Q&A once they have a chance to just talk through the work that they do. So does that sound right, Amy? Oh, you're on mute.
Some of the goals of our event tonight are to try to foster a recommendation that would allow folks to really be able to participate in the future growth of the BHU unit, because I already know they're a benefit to our community. And I really think it's important that the community understands that the more units we have available, the more people can be engaged. So our goals are to come up with some form of a recommendation that to assure that the behavioral health unit stays on and is expanded in order to accommodate the need and growth in our community of folks needing assistance. So I just wanted you to all know think about something you may want to create a recommendation around, and let us know, because yeah, we're working on things we can present to the mayor and then hopefully get enacted so that we can become a more equipped city and have the services we really need in all the different areas that are being served by our population. So thank you, Casey. Yeah, go on. I'm gonna unmute.
Well, no, you're good. Thank you for the opportunity, and we appreciate the chance to speak with all of you and answer any questions that you guys might have. So as I throw it over to Billy and Sarah, and then Cindy, if she wants to jump in as well, I'm going to throw my email address into the chat box so that if you guys do have any follow-up that you want to do, any questions that don't get answered tonight, or if you want to engage in more conversation, by all means, just reach out to me and we'll see what we can do to help facilitate that. So with that, I'll kind of throw it over to Billy and Sarah and Cindy if they want to take it from here.
Okay, I'll go ahead and start. Thank you everyone for having us. I appreciate the opportunity to talk to everyone and tell us, kind of more about what we're doing. So I'm just going to start with I'll just introduce myself and explain what my role is, a little bit of history of where I come from, and I'll pass it on to Sarah so she can do the same thing. I've been a police officer for about 5.5 years. Prior to that, I worked for the behavioral health unit in a non-sworn capacity where I ran the service coordination team for a couple of years, which is a program that we still have running now, and it's more focused on addiction, co-occurring disorder treatment, and housing for folks who are struggling with few resources. Prior to being a police officer, I actually spent the majority of my previous career in mental health and homeless services. I worked for TPI. I was an operations director at TPI for a number of years. I ran one.
I think we lost your sound. Are other people having trouble hearing him as well?
Am I freezing up? Or can you guys hear me?
Go. Yeah, sometimes if you turn your camera off, you can your sound works better.
Okay. Where did I leave off?
Working with TPI.
Okay. Prior to that, I worked with homeless youth and New Avenues for Youth. I spent a few years there as a program coordinator, and before that, I worked with youth and kids in mental health services that were in residential and residential treatment facilities, all in Portland. I've worked in downtown Portland for over 20 years now, mainly in the Old Town area. So I'm very familiar with the area. I know a lot of folks on this committee from back in those days. I've crossed paths with a lot of people over the years. But right now, what I do is I work with Sarah, who's a licensed mental health clinician. And our job essentially in a nutshell is to find folks who are struggling out there, living on the streets, living outside, who are struggling with severe and persistent mental health issues, who are in the throes of addiction, who have very little resources or very little connection to anyone. And our job is to try and make contact with them, build rapport with them, and then somehow navigate.
Whoops, there you go again.
Can't hear you again.
But you don't actually look like you're freezing. Still can't hear you.
Am I back?
Yep, now you're back.
Sorry. I can tell if people start smiling when I'm frozen, so I'll just stop whenever I see people smiling. So like I said, I don't know where I left off, but am I here? Thumbs up. Okay. So the job is essentially to find folks and help them get connected to services in whatever capacity that looks like, whether it's try to get them connected to housing.
No.
I can take over for a little bit while that gets situated. So my name is Sarah Hattal. I'm a licensed clinical social worker. I'm a Cascadia project respond clinician contracted with in their behavioral health unit. I've been with Project Respond for 4.5 years and with BHU for about 2.5 of those years. Like Billy was saying, our whole goal is to engage with folks who are either having a lot of police contact due to their mental illness or have escalated behavior due to their mental illness that's unsafe, and try to get those folks connected to the appropriate resources, whatever that may be, to relieve their crisis and reduce the amount of police contact that they have. Billy, are you there?
Yeah, I'm back. Can you hear me?
Okay, you're good.
Okay.
Yeah, we can hear
I'm gonna leave my camera off just so I can hopefully have a better connection. Yeah, I mean, I'm just gonna connect what Sarah said. So we essentially try to find connections for people. We want to contact people who are in crisis and try to guide them out of that crisis in the safest, most humane way possible, and connect them to services that exist in the city, so that not only, and it's like I said, it's not about just reducing police calls. It's about reaching folks who are hard to reach with just kind of the normal services. And like I said, I'm very familiar with those services look like and the capacity. And so one of our jobs is to find ways to get people into those services, even if it takes some creative thinking, you know, kind of how we do it. Our job is largely crisis intervention, crisis communication. We are wholly dependent on de-escalation skills and you know, and making sure that we try and connect with folks so that we can get them to whatever connection point they need. We see ourselves as kind of people who are, you know, are facilitating those connections. We're not providing service. We're helping get those folks to those points of entry into the system as best as we can. Also with you know, approaching situations that potentially dangerous, that, you know, have folks who are in serious crisis with, you know, both sides. We have from the police side, we have you know, the ability to approach it even if it's unsafe, and then we also have a clinician side, so we can kind of deal with whatever is thrown at us. So now I'll pass it to Sarah and let her kind of explain a little more.
Yeah, and I think what's great about this, about the police officer clinician partnership, is a lot of times we find that someone may not want to speak to me because a part of their illness is not believing that they have an illness. And so by speaking to me as a social worker, that would confirm that they have a mental illness. And so they would rather speak to the police officer, or vice versa, you know, not wanting to speak with a police officer for a variety of reasons. I can step in and speak with them. A lot of times it's really collaborative in working together and working with folks. I think one of the greatest things that I love about our unit and the work that we do is the flexibility we have in really meeting people where they are at. Like today we were working with a client, and he was asking about like what kind of resources we have, and you know, besides, you know, the connection to mental health resources and housing and all the kind of standard resources we can offer, it really is, you know, meeting people directly where they're at, outside or wherever their environment is, and trying to piece together whatever sort of plan or resources or meet their basic needs in the moment. So that way we can then move on to the bigger steps, such as getting connected to mental health resources. Because for someone who's living outside, it's really impossible to expect someone who is struggling with mental illness or substance use, who doesn't have a phone or a calendar or is not taking medications or have a support or transportation, to make it to the appointment that they need to have an intake or whatever that service is. So we really try to work with folks to get their immediate needs met, and build up from there. And so you know, we'll do whatever we can, like taking people to appointments or to the hospital if they need, or coordinating with family to get birth certificates so they can get an ID, so they can get permanent housing, or, you know, really whatever it is, trying to meet people's needs to get them out of the situation that they're in. And that looks different for everyone. So I think that's what a great thing about what we do is, like Billy was saying, the kind of the creative problem solving or resource connection with folks. Yeah, I
think our reach is pretty unique too, because we are the ability to contact people when they're in custody, when we can, you know, work with people around their warrant status. We can talk to POs. We can, you know, we can communicate with mental health providers, with drug and alcohol providers, with housing providers. We can kind of, you know, run the gamut of all the providers that are there to try to problem solve with folks wherever, you know, depending on what their needs are. Which, coming from my background as being, you know, in social work primarily, I think that was a difficult, you know, it was a change coming over. Am I frozen?
You're good.
Okay, sorry. So yeah, I mean, it was like, so I've found that working in this capacity, I'm able to kind of access a lot of different avenues for folks, more so than I could before, when it felt just a little more siloed. But I also have, you know, we have what we call, you know, we try to make friends across the board. So we have connections with folks in all different resource arenas, and our, you know, that the whole idea of that is essentially what, in my opinion, what community policing and what, you know, community-based approach is all about, is all of those different sectors coming together. So that if we have someone who, for instance, today we had someone working with who's camping outside. She's got mobility issues. She's got some clear mental health issues. And so we were able to talk to her case manager at Kaiser, who's talking to the county at aging and disability. But we can also talk about her basic needs and the fact that she needs blankets and, warm clothing right now. While we're doing that, we can start problem solving and planning for a longer term transition for her to get somewhere into some kind of a stable housing or support housing through her case managers, through the hospital, through the county. So it's just a multi-level that we have contact with, and we're also mobile, so we can go around the whole city and find people if we need to. Fundamentally, what I think the value of having teams like ours is that we are, we can be on a lot of different planes at once. We can contact a lot of different resources at the same time. We have a lot of institutional knowledge on all institutions. So if someone has legal issues, we know how to navigate that. If they have, if it's mental health or medical stuff, we have connections with all those folks. So it's almost kind of like a souped up version of outreach and case management, but like I said, we're not really managing the cases. We're helping connect people to the right folks who can, who can get them what they need. And I think as far as, the population we're serving, over the years that I worked in downtown, I've seen the population of people living outside double, if not quadruple. I think the need is out there is increasing every day. And I think that, the city is at a point where I haven't seen it before. And I think that at this point we need folks who are going to be able to connect those points. And so far it seemed like it's been a really good partnership working with folks in the mental health world. And we also, we're making connections and making alliances with folks as a police officer. We're making alliances with folks like Sisters of the Road and places that historically haven't been, as aligned with the police as we would hope. And I think that's something that comes out of our, what we do that is extremely beneficial when we're working with the same population and trying to find solutions for people that are really, really hard to engage with or get to the right, level of service. And I apologize for my
I just want to provide just a quick context or clarification for the group. So folks that aren't aware, with our scaled crisis response model that we have at the Police Bureau, our 5 VHRT teams, our 5 co-responder teams in VHU, they're not our primary responders to the in-the-moment hot call or emergency calls that are involving mental health crises. The way that that's structured within the Police Bureau, that those calls are the responsibility of our ECIT, our Enhanced Crisis Intervention Team officers. And as you probably noticed in the chat a little bit earlier, we're going to be having one of those officers, maybe 2 of them, come to the January meeting to talk more about their work. So while Billy and Sarah are out and about, they basically have a radio on and they have the ability to go assist with a call if one happens to pop up, but they're not tied to the radio for emergency responses. So that freedom really allows them the time and bandwidth to actually meet with and work with people for sometimes multiple hours or 6-8 hours sometimes without having a break in there being pulled away by the radio. So just some context and some clarification for the group, just so you kind of are understanding how we have things structured, that it's not typically a BHU officer that's responding to an emergent mental health crisis call typically.
And I'm not good at looking at the group chat question, so I'm sorry we didn't get to this before. I saw Ann Casper's question about, clients preferring to speak with police over the clinician. And I do think that's true. I mean, just today, the woman that Billy was talking about who is living outside with mobility issues, she asked who I worked for, and I told her I was with Cascadia, and her disposition immediately changed because she had experiences with that before about having her rights taken away. And so, I think that's a really valid thing that folks experience, because it can be really traumatic when folks go on a hold. And so they can be hesitant to talk to me or fully disclose what they're experiencing.
So is there any other, specific questions that people have about what, or do you want me to describe kind of a day-to-day?
Yeah, and what a navigator does.
What exactly, okay, what we're really looking for is like, what would the process look like from the minute somebody sent out a call? You know, like from the time the call comes in and the situation involves someone who might be a little bit irritable or having psychosis,
It's
like
not the BHU that comes out.
what would be the process for the next like piece of engagement? Help us understand how the engagement process works through this whole system, because it's
Okay.
kind of sketchy for me.
So if we're talking about hot calls, we're talking about if someone calls like 911 saying that there's someone in crisis, is that what you're talking about? Yeah, okay. So someone,
Yes.
if a call comes out and it's a call of someone in crisis, say it's a welfare check, say someone hypothetically someone says, you know, there's a welfare check, we need a welfare check, this person is acting erratically, they're standing outside of the Bud Park Commons, and it appears that they're having a mental health issue. The best case scenario is an ECIT officer is dispatched, so it's an enhanced crisis intervention trained officer, is dispatched to the call, assesses the call for any sort of mental health nexus, anything that would indicate that mental health is involved in the call, and then the immediate response is going to depend on what the situation is involving, whether it's the person needs to go to the hospital, needs to get transported to Unity, potentially a police officer hold or a director's hold, or if it's just something you can de-escalate and try to find connections to services. A lot of times folks are frustrated that they're trying to get connections to services and they can't do it, or they're in fear of something, or they're they're just frustrated by the situation that they find themselves in. So the goal is to try to find de-escalate the situation as best as possible and find the most efficient and helpful solution for that person in the moment. I mean, that's kind of the goal of every officer who's going to intervene with that person. Our role comes in is after that call is kind of sorted out, where the outcome is, referrals can be made to us so that we can do follow-up with the folks that are involved, with the individual involved. We can try to make connection with that person, see if there's any further involvement or any engagement that we can provide, and connect them to services that are going to be longer term, so that they're
We lost Billy.
We lost you again, Billy.
I can fill in maybe a couple of the gaps. So the work done in the BHU, we rely upon referrals that we get from patrol and throughout other parts of the police bureau. So we have an application that officers have an ability to submit a referral to their computers in their cars or the computers in the precincts. And all of those referrals come to one of the two sergeants that oversee the BHU. And they will research those referrals and triage them, and then decide if one of them will be assigned to one of our 5 teams or not. And some statistics on that is we've got about 1,000 referrals per year. And on average, every year we're referring or assigning about 50% of those to a caseload. And on average, most folks are on a caseload for about 25 to 30 days. Some obviously are much shorter than that, and some are much longer than that. Some folks are with us for several months at a time. And the average caseload for one of our teams is about 10 to 15 people, although Billy and Sarah typically carry a much larger caseload due to the fact of the clientele that they're working with and the nature of it being a little bit harder to locate some of the folks that are unsheltered or unhoused.
That was awesome. Thank you. Now it's starting to line up. I'm going to open the floor and ask, is there anyone with questions for anyone in particular? If so, we have a raise your hand feature in the chat box, or you can put your hand in front of the screen, whichever is easier for you.
And Amy, Taji has his hand up, and it's actually in the participants box.
Okay, because I can't see it from here, so you'll have to help me.
Yeah, absolutely. And can I just quickly say, Billy, if you have problems with your microphone again, you could try calling in on your phone. There's a number that came with the Zoom link. And then you could be both on phone and on picture, and we would hopefully not lose you. Taji?
Yeah, I think it's my connection. I'm sorry. I'll try. I might have to sign out and sign back in.
Okay.
Cool. Oh, thank you so much. So I want to try to keep it so that other people can ask questions. So I'm just going to ask two. First is, what do you see as the metrics for success when handling those caseloads and sort of once you try to transition folks out of being or having a case? And then the second one would be, what do you see as your biggest differences from the Portland Street Response team? If any. Cool. Thank you.
Yeah, for metrics for success, I mean, Billy and I have this conversation all of the time because what we would like to view sometimes as success for someone would be getting them housed, getting them connected to mental health services, and getting just fully wrapping around them. But that's unfortunately just not realistic a lot of the time. And what success is for one person is totally different for another person. And so we try not to make a mold of what success would look like because it's different for everyone. And so for someone, it could be because, you know, it's a lot of people don't want our help either. And so we respect that. And so it might be helping someone get their EBT card. And they may not want housing, but that's the only thing they want. Or they do want housing, so we can help get them connected to there. And that will be a success. Or if they're in a serious crisis, getting them to the hospital and coordinating with the hospital while they're safe so they can get stabilized, we view as a success. So it really just is so variable from person to person, and we try to keep an open mind of what success is. So I think it's keeps us moving in a positive direction.
I think too, the biggest difference between us and the street response is that if we have the capacity to engage with folks who are potentially in, you know, dangerous situations. I think there's a lot of situations that involve weapons. There's a lot of situations that involve people in crisis that are not necessarily safe situations for folks to engage in who don't have that kind of training or those kind of tools. I think there's a lot of situations that we go into that I don't think a clinician and a medic are going to approach or going to be able to approach safely. So I think that there's definitely a need for as much help as possible, but I think there's going to be a point where the limit of what the street response is going to be able to respond to is kind of where we start and keep going.
I'd like to add that if I could. So I think one of the main goals of the BHU is really to reduce police contacts and effectively connect people to the right services. And we have a full-time data analyst that works within our unit, and he looks at several different metrics and numbers to ascertain performance measures and how effective we're being in living up to that goal. And he's been studying this since the inception of BHU, and the numbers are currently telling us he'll look at a cohort group from when you consider an individual 1 year prior to BHU intervention and compare it to 1 year after BHU's intervention once they've cleared our caseload, we're on average seeing a reduction of 42% of police contacts when somebody's had that BHU intervention and cleared our caseload the year following. And we're also seeing in the same time frame a 9% reduction in arrests for the same population as well. So we have a number of performance measures that we're constantly evaluating, and we're always looking to find efficiencies and find ways to be better equipped at helping these folks. And just to follow up on the Portland Street Response, I actually had the opportunity to go down to Eugene almost 2 years ago with a couple of Commissioner Hardesty's staffers to meet with and review the Cahoots program. And in talking with the folks that are actually doing the work down in Eugene, one of the things talking offline with them that they say is missing from their program is the follow-up capacity. And they they lack the ability to meaningfully engage folks in more long-term problem solving. They're kind of more in the moment, dealing with the crisis event or the subacute crisis situation, but they're potentially dealing with the same people or working with the same people on a daily or weekly basis without the ability to actually change their circumstance. And so I think that's where BHU is substantially different, in that we actually have the ability to actually dig in and get to the root of the issue and make meaningful change for these folks to help improve their situation.
Casey, I have a question for you, or for Cindy Hackett, who's been doing this a very long time. What is the relationship between like the healthcare providers, the mental health care providers? Where do you see the majority of people needing to like connect with more or less the most? How do you play out with all of the different providers that are out there in the community? Does that make sense? Like, what's your connection with the physical health providers? You said you take people to Unity. Do you have relationships with the staff at Unity, or is it just kind of a drop-off option? I'm trying to see what kind of relationships y'all have with the rest of the working community of healthcare providers.
Yeah, so we have some pretty strong and robust relationships with the social workers at the various hospitals, EDs, Unity, and then all the other different resources that we routinely utilize. And then we also convene a biweekly meeting on every other Thursday. We call it our coordination meeting, and we will staff individuals that are intersecting a number of different areas, whether it be the jail. We have corrections health representatives, we have parole and probation there. Unity comes, some of the hospital folks come, forensic diversion comes to that meeting. And so we utilize that space to best plan for and advocate for individuals that are touching multiple places or systems all at once. And I'll let you guys jump in if you want to add to that.
Yeah, I mean, I think the partnerships in the community is extremely helpful in what we do. If we take someone to the hospital or find out that someone's in the hospital that we're working with, we do our best to get in touch with the social workers that are working with that client. And same with like any medical providers or outpatient mental health, just to make sure we have all the information that we need to know about working with this person that will be helpful, and vice versa, like what information we have that we can give to them that would be helpful, just to wrap as much around this person as possible to aid in their success and their stabilization. So there are a lot of community partners that we work with really closely.
I think the partnerships are probably the most important thing that we have going on. We have relationships with a lot of folks that allows us to do our job. And I think speaking to that, there was a chat question about why the police should be involved in like short.
We lost you.
We can't hear you.
We can't hear you. Still no sound.
Sometimes if you remove a headphone, it magically works. Sometimes doesn't, but that's one trick.
Oh, okay. So Billy, you might try.
Say that one more time.
Using the computer microphone instead of your headset.
Oh.
Which also has a microphone and it has limited capabilities.
Yeah.
Yeah, you have to unplug it though.
I might have to just call back in. But quick, okay. While I'm here, let me just finish my thought real quick. I think that the reality is that we deal with folks who have oftentimes been excluded from all the services available. People kicked out of shelters for aggression, people who are on the streets who are, they're not engaging with anyone. And oftentimes they're aggressive, or they have, other barriers that are that make it difficult for outreach workers and social workers to engage with them. And I think that is where we have the kind of unique ability to approach them safely and try to re-engage when outreach workers or short-term case managers can't really do that.
Thank you, Billy. We have a lineup here of folks. So we have Jiro, Patrick, Taji, and Jared.
Yes, sounds like I'm first. Okay, so my question is, maybe I'm a little bit old, but I heard BHU was inside a part of ECIT, but maybe is that changed in more independent? That's one question. Other is pressure. If you call 911, if it's more suicidal, then project response show up. So I like to know a little more big picture around there about who show up, what situation.
Yeah, so the ECIT program is actually under the umbrella of the behavioral health unit. And those officers are deployed amongst patrol to all different of the 3 different patrol precincts that we have within the police bureau. So they're spread out amongst all the different precincts, shifts, and districts so that we have best coverage. So that any time of day or night, we ideally will have those ECIT officers deployed in a way that they can quickly respond to a situation. And then, can you remind me about the second part of your question?
I heard if you call 911, then suicidal situation, then mainly project response show up. But is that
perhaps? Yeah. So that's a protocol that that changed a few years back, and we've worked in concert with the Bureau of Emergency Communication. That's our 911 dispatch center. Mm-hmm. And say somebody does call in with a suicidal ideation, however, they don't have a plan in place or they don't have the means readily available, they will deem that as kind of a lower acuity call, and they will do a warm transfer to the mental health, the county's crisis line or the county's call center. And they will not dispatch police to that call.
Okay, so you said DMAT.
What's that?
You said DMAT. What does DMAT means?
I'm not sure.
Oh, so you didn't say DMAT?
No, I must have misspoke.
Oh, okay. That's maybe
the Multnomah County County Call Center, or the crisis line, which is what it was formerly known as. So if somebody is suicidal and calling in they don't have the means or method or a plan, we deem that as maybe lower acuity, and that will be warm transferred over to the county crisis line or a call center, and then may dispatch project respond to follow up with that individual. And that's a deviation from what used to be done back in the day, whereas anyone that called in expressing suicidal ideation would get a police response no matter what. And we didn't feel like that was the most appropriate, and we've changed that. And I think it's paying dividends, getting the appropriate responders and resources to folks that need it.
And project response, or police too, if police arrive on scene, whether it's to a suicide call or any call that's involving any sort of mental health nexus, and they feel like there needs to be more mental health support, they can page Project Respond directly and get Project Respond there. So Project Respond can be dispatched either through the Multnomah County Call Center or directly through police. Gotcha. Then
I heard usually Project Respond team with one police officer show up together. Is that true?
So it's it's dependent on the team that's going out. So the team of, it's 2 clinicians, they'll assess the call and the situation and determine whether or not police will be needed. So sometimes they go without police and sometimes they call police for assistance as backup.
Gotcha. Thank you very much.
You're welcome.
Okay, Patrick, your turn.
Yay. I had 2 questions. Both of them are fairly short, I think. Who does your de-escalation training for the BHU? And then secondly, the biweekly meetings you were talking about was the BHUAC, I think. And, oh, okay. And how many people on the BHUAC are people with lived experience of homelessness or mental health or a mental illness?
I'll take that last one first. So we do have, actually I'll take the middle one. So the biweekly meeting, the coordination meeting is not, that's different than the BHU advisory committee. The BHU advisory committee just meets once a month. The coordination meeting is the one that meets biweekly every other Thursday, and that's one that has all of our coordinating efforts with the community health providers, law enforcement, and other providers that are interacting with these individuals, similar individuals. And then as far as the de-escalation training goes, we do some of that in-house, and then we also, when we do our ECIT certification courses, we have a number of folks that come from outside and provide crisis communication training. Folks that's their field or industry. And then also folks that are working within BHU specifically, we also utilize external trainings to kind of get folks up to speed with best practice and whatnot. So.
And how many people on the BHUAC are people with lived experience of homelessness or mental illness or mental health crisis even?
Well, that's kind of not everyone self-discloses their personal history. We do have a few folks that do self-disclose. I think we've got 13 or 14 full members, and I think we have at least 4 or 5 folks that self-identify as having had that experience.
Thank you. Now we have, and then Marcia. And then I'll get to yours in the chat box, Amber.
Sorry, Judith, was there someone before me?
Jared had a question. Are you?
Yeah, and I was fine to go last, but since you put me up, I appreciated Sarah's comment about success being individualized to the client that you're meeting with. I was wondering broadly if you might, you and Billy might speak to what you think would help your program be more effective as a whole. Like what don't you have that you think would make you more effective at achieving those individualized successes?
That's a big question.
Start with that one. Can you hear me?
Yeah.
Can you hear me? Okay, all right. So I mean, Sarah and I talk about this question every day, all day. I think one of our, frustrations is, we do a lot of work to try to engage folks who are hard engaged, try to get people out of the crisis cycle, and deliver them to the system that, in our view, hopefully can meet their needs and address what is happening and alleviate their suffering and get them, where they need to be. And often to find that system is either at capacity or inadequate or hard to get into. I think that for us, the VHU through the STT program created something called the STS program, which is kind of an immediate stabilization, short-term stabilization program for folks. And that seems to be one of the most valuable tools we have. So when we're asked what we need to be successful, we need a place for folks to be. We need a place for them so we can help people get somewhere, so that we can help them stabilize, so we can get them some kind of safety and structure so that they can start to address the things that are really impacting them, the mental health issues, the addiction issues, just living on the streets, the fear, the victimization, the things that they're suffering from out on the streets. We need a place that we can get them so that we can help reverse that process, or at least alleviate the suffering for as long as we possibly can in order for them to get some kind of stability. So our goal is to address the underlying issues that we find people are dealing with on the streets, and those are the big things. It's poverty, it's mental health, it's addiction. The fact that someone is, stealing stuff from a 7-Eleven because they're living outside and they have to feed methamphetamine habits to keep themselves awake all night so that they don't get victimized by people is a symptom of the larger issues that we're trying to address. And so I think for us, it's about tangible resources, brick and mortar places where we can actually bring people that they're going to be, they have access to, whether like they're going to be safe, they're going to have access to the things that they need to help stabilize. That's our biggest obstacle. We're pretty good at engaging with folks, at building rapport with people, at convincing them that we're not there to just arrest them or, you know, take them away to a hospital, but we actually sincerely want to get them help. The problem is that when we don't have anywhere to go, we don't actually have access to that kind of help. It undermines everything that we're trying to do.
Thank you. Marcia?
Yeah, thank you. This is a lot of really good information. I really appreciate it. I think there's a combination of folks' information and questions that that bring me to mind, which is, you know, what is it about the police presence and the collaboration that makes your outcome so successful? And then what are some of the unintended consequences of having police involved in this? And Billy, you kind of mentioned like this need really for mental and behavioral health services or the system in general. To me, when I look at it from a grand, you know, large scale perspective, I mean, police probably shouldn't be doing this work. I'm glad that you're doing it in the context that we're in right now. And also, it sounds like, to Jared's question, like we need the actual systems to be effective so that you don't even have to do this in the first place. So curious, what are the unintended consequences? Like, are we letting the mental and behavioral health system kind of off the hook by having police have this robust, amazing program? And also, what's potentially happening to the folks that fall through the cracks of the program when you are involved in what other systems are involved? You mentioned parole and probation. What happens to communities of color who are disproportionately impacted by decision makers in the, you know, in the rest of the system that you don't necessarily have control over? So
yeah, I mean, I don't think that we're letting the system off the hook, honestly. I think that one thing that the Police Bureau does very well is keep people accountable for things. I think that we are part of that process of, you know, if we're going to engage with a provider and, you know, we go through a lot of work to get somebody, say, to a hospital or to, and the response is, oh, we're just going to cut them loose. We have no problem pushing back and saying, well, this doesn't make sense. Like, what are we trying to do here? We're trying to actually, you know, find a solution for folks, and we want to be a part of that process. I think that from my perspective, that the kind of intertwining of police and the mental health system and the larger social service system is something that we're going to be contending with for years. I mean, if you look at a day's worth of calls at Central Precinct, you could sit there and just reading the call say, oh, this has something to do with someone who has some sort of crisis, whether it's mental health, addiction, whatever the crisis is. But I think that our system isn't set up yet to receive that, you know, that capacity of folks. So I think that the police involvement is inevitable. I think what we're trying to do is we're trying to reshape that involvement so that it meets the need of the client instead of it being a straight law enforcement approach. We're approaching it with a more thoughtful, holistic approach that, you know, that includes the mental health systems, the social service providers, the addiction system. And it's kind of, you know, it's a difference than what it was before. I think we rely, like we said before, on relationships with providers. And those are all things that, in order for us to do our jobs effectively, those need to be in place. I also think, and I thought this when I worked for TBI, that as someone who was working in the homeless system, if I wasn't working to put myself out of a job, then I wasn't doing the right thing. Like, you know what I mean? Like, that should be the goal of every service provider or every, you know, nonprofit, is that if you're trying to, you know, affect homelessness, then someday your goal is that homelessness isn't going to need you anymore. I think as police, like, we recognize that we are, you know, we're in this situation, but we also, you know, we're trying to get it so that the community is healthy, the community is safe, the community has the resources it needs to address the issues that it has, and then our role can be clear and defined, and what we should be doing. I think right now our role is, like I said, it's inevitable that we're going to be involved in some of these mental health issues and crisis calls because they're dangerous. I mean, they're dangerous folks, and they're that are, they're dangerous situations and they put people in danger, and we have the ability to respond to that where other people might not. I think ideally everyone would agree that mental health is, is best treated through the mental health, through the mental health system. Addiction is best treated through the addiction system, and crime and criminality is best handled by the Department of Community Justice. But right now there's such an overlap that there needs to be, it's a more nuanced thing, and there needs to be a thoughtful approach right now until everything is kind of in place that we can fully rely on the systems to, maintain their part of the puzzle.
I think we also have a unique opportunity to advocate for people too that wouldn't otherwise have a strong voice, that don't have familial support or other folks that are there trying to help them along. And so we become the de facto advocates for these individuals that have been failed by every other system. We become the people that are championing them, and we can utilize and leverage our relationships that we have with these providers and systems to actually make something happen and hold the providers accountable to make that happen. And we are constantly doing that on those biweekly meetings where we're coordinating for these individuals that have been turned away or failed through or fallen through every system that's out there, sadly. And one of the guys, I'll use my corny analogy that I use in all these meetings, Jim Stegemeyer, who used to be our CIT coordinator, talked about the analogy of having a waterfall. You can either build a fence at the top or a hospital at the bottom. And we're definitely in the world right now where there's a hospital at the bottom and you have a bunch of cops that are feverishly trying to catch people that are falling over the waterfall and get them to the hospital. But in a perfect world, we wouldn't have to do that. The behavioral health system would work as it's intended, and we wouldn't be involved in these situations. But sadly, that's where we're at. And I fear when there's talk around defunding police and the reimagining things, that the idea is to do it in a very hurried manner without having those other systems in place and well tested and able to take the capacity. I think we're just going to further fail these people, and it's going to leave them even worse off than if we are more thoughtful about how we make these transitions to an alternate response.
Thanks,
Hello.
Kate. So I've got questions from Amber. Do you want to ask them, Amber, or do you want me to read them?
Can anyone hear me?
Yes. Can you hear us?
Yes, I didn't know who you were speaking with, but it seems like whoever is monitoring the phones, that you're forgetting that people are online and not on the computer. I just wanted to make a comment with the person that was just last speaking about those that are homeless and in need of care but are not really getting it. I know Multnomah County is supposed to be over a lot of these resources with the providers that are out there, supposedly providing the care. I just wanted to ask one of the officers, what are you seeing as far as the population that you're dealing with, as far as where the people who are homeless on our streets, where are they coming from?
Are they coming from, are they local, or is that
Well, that's why I'm asking the officers who deal with the homeless, whether they get them into resources, if they, if this is a case that they're responding to a crisis or whatever, when you're working with those clients, trying to get help to them, can anyone tell me the majority of the population that's being dealt with, where they're coming from? Are they local people, or are they people coming into our city?
I mean, I think for us, that it would be hard to determine, whether or not someone was local. I think many of them have been here for, several years, whether they are, born and raised here or come from Portland or locally. I think that the majority of them have been here around for a while. Like I said, I've worked in homeless services for a long time, and I know a lot of folks for years. So I think it's just kind of a mixture. I definitely think the population is increasing. Just in general, and people are coming from all over to Portland. So I think that has stake in it, but I think that, it's hard to determine whether or not someone is actually been here for the most of their life, or if they've transplanted from somewhere else recently.
And can you tell me, with the meetings that you have, you mentioned you have meetings, coordination meetings with the providers there. Is the county usually involved with your meetings?
Yeah, they are. There's representatives from a lot of different county bureaus. There's a lot from Department of Community Justice, Parole and Probation. There's mental health court. We just got someone recently coming from the Developmental Disabilities Program. And we have contacts within, aging, disability, and a lot of the other county.
Okay, and have you heard from those partners from Multnomah County what their resources are, coupled with the, dealing with the COVID situation and the CARES Act funds that are coming in? Are they saying that they're getting more funding or not for the homeless?
I'm not aware of that. I mean, I'm not.
So,
I can't see.
well, so as far as the resources that you're dealing with, are you guys hearing as you're having these meetings? Are you hearing from anyone that are partners that more resources are coming?
I mean, that's not typically brought up at the meetings that we have, right? The meetings we have are usually aimed at direct coordination for individuals. I'm not sure if there's higher level meetings talking about funding.
Just watch.
Do you guys get follow-up?
One last question, because we have a whole bunch of people with their hands up as well.
First of all, I really would appreciate your name and where you're from, because we don't get to see everything when you're a phone number. It doesn't show up on the screen, and I don't want to leave anybody out. And unfortunately, you're only showing up as a number. So if you could introduce yourself to 503-502
hey, Amy, that's me.
Other one, it'd be appreciated.
My name is Marie, and can I finish and then I'll shut up? I just want to make sure that I get these. These are some important questions that I'm asking.
Sure, but
because I just want to know.
Feature.
I'm sorry?
There's a hand-raising feature that we are using that is not available on your phone, so you can't see our process. So you jumped in line. We have a line going that others can see that I don't think you can see. And so we want to hear from you, but we do have a process.
So Marie, why don't you finish your question and then thanks, Amy, and then we'll move on to the other people.
The last question that I have, because I thought I had the floor, and I didn't know if I had a set amount of minutes to speak at all or not, because I'm on the phone, okay? And so the last question that I have for the officers or the people who respond to the homeless that are out there, do you guys, when you have your coordination meetings, and let's say you take a person that's in crisis to the hospital, or you put them in treatment, or whatever it is that you do with them, do you work with anyone that does follow-up services with these people?
Yes. And part of our job is to provide follow-up services to try and make sure that we can help navigate them to services.
Yeah, so a lot of times when someone's in the hospital and we've been working with them, we'll collaborate and work closely with the hospital staff. So that way the person is either connected to some other resources, if it's not us, or we have a plan with that person upon their discharge.
Thank you, and thank you for your questions, Marie. We appreciate it. Sorry about the
Thank you.
So Amber has two questions that I'm going to read. One is, are the officers currently certified for crowd control and less than lethal munitions right now? Last I was aware, training hadn't been done since last November. And the next question was, are these safer places for them to be worked out and an alternative in place for specific people when homeless camps are swept? Does anybody want to take those?
As far as I'm a little bit confused about the crowd control question. Are you speaking of the officers in general within the police bureau, or the BHU officers specifically? Well, I can't speak to that. I know that I think you might be correct in that the last time we had full training around crowd control stuff was last November. We did have some updates this year that have been pushed out, obviously, due to the nature of what's going on. But yeah, I wouldn't be the best to speak to that. And then, sorry, Judith, the second part of the question, or the second question?
Does that have to do with the sweeps?
Yeah, I'll just take myself off mute. Yes, I'm asking about the sweep. So a lot of what I'm hearing is kind of surrounding a lot of the issues, and it seems like we're talking about, you know, exceptions to cases where, you know, a large amount of homeless people are displaced with nowhere to go, no system in place for them. So we talk about taking people to the hospital, getting them in programs, and you know, that's one here and there, but at the same time we're displacing, you know, upwards of 50 people in one breath in one afternoon. And I'm just curious, you know, am I mistaken, or are there no safeguards for those people when they're swept?
I think that may be a little bit out of BHU's purview. That the camp cleanups is more under the purview of the Huckert program within City Hall. I know that I think Billy and Sarah will reach into some camps occasionally if there's individuals that need our services and need help getting connected. But as something that's happening routinely, I don't know, you guys can correct me if I'm wrong, but I think on the wider scale, that's a question better suited for somebody not in BHU, being that we're just strictly working with folks with mental illness or substance issues that are with co-occurring stuff typically.
Yeah, our involvement with the camps, I mean, we do a lot of outreach to folks living outside to see if there's individuals that we can help connect to services. We're not involved in any camp sweeping. We're not involved in cleaning up camps. And the focus of our attention is to try to find folks who are in extreme crisis, who are clearly having problems taking care of themselves, who are very vulnerable, who are you know, living outside in pretty horrific conditions, and trying to get them the services they need so they, you know, can not be in that situation anymore. As far as like how the city responds to camps or how they respond to businesses, you know, asking for camps to be swept up their property, all of those things, that's going to be a different part of, it's going to be a different group that's overseeing that.
And if folks are interested, we can make that a subject of study at another month's meeting. So we can always learn about these various programs as we go forward. So thanks for asking about it, and we're going to move on. Go ahead, Judith.
So, yeah, so let's have Barbara, and then we have a question from Jan Friedman in the chat, and then Amy White, you have your hand up. You can take us out as the last person, because we're running out of time. It's been
yes, I will be last. That is fine.
Okay, my name is Barbara Boshinsky. Amy, I heard you earlier talking about how you were able to de-escalate a situation with a man with a gun, right? And so I'm wondering, is it necessarily true that if the situation is dangerous, that the police are necessarily the best people to be there? Because sometimes people see the police as escalation, maybe? I don't know. Do you remember, Amy, what you were talking about?
Well, what I was talking about was the man was threatening to shoot me. Basically, what he said was, if I had my gun on me, you'd be dead. So I don't know whether he had a gun, whether he didn't have a gun, but it sure felt very intimidating and very scary. But I was able to use techniques that I've been learning working with the houseless communities and others that are extremely violent and dangerous. And that is a de-escalation technique of not really engaging in any kind of negative behaviors, conversations, just like totally ignoring them. So it may not work in all situations, but sometimes, yes, clients and people are intimidated by police officers, and other times they want them there. So I'm finding some people enjoy them being on scene because they feel secure, and other people are triggered and they run into the street and get hit by a car. So it just depends on the individual. And I also want to add one more thing, and then I'm going to stop, and that is a lot of folks after a certain point don't want to be engaged. They absolutely want to live the way they're living. They like being on the streets. That's their family now. They've been displaced so long, they've actually made families or connections in these areas, and they like it there. And some can never get housed because of their criminal background. So there's a lot of variables folks just aren't aware of that I've recently become aware of. So just keep that in mind too, is not everybody wants our help.
Thank you. Jan, do you want to ask your question, or would you just like me to read it?
All right. I'll just essentially read it. I'm just wondering what ideas you have for outreach with the community that you'd like to make for PCCEP and this subcommittee on behavioral health in particular. So that's one question. And then another is right now, how are community members able to engage with BHU or BHUAC, and whether you think that's sufficient.
Can you, what was the first part of your question again? Sorry, Dan.
Okay, so I'm going to even simplify it more. One would be your suggestions for outreach for this particular subcommittee, you know, in relationship to the BHU. And then the next would be how currently can community people engage with the BHU or BHUAC? And if you think that that's sufficient, whatever it is that's set up currently.
Yeah, so the BHU Advisory Committee took up this issue earlier this year and finalized and approved a community engagement plan. And a number of those action items have been put into place. The last couple remaining things that have been a little bit longer in taking effect have been limitations due to the COVID. But we've presented to this body a couple times as the BHUAC. The website for the BHUAC has all of our agendas and all of our minutes listed on there. There's a dedicated email address for folks to utilize to ask questions or suggest things or inquire about things. All of the members are listed on the website. So if someone has a relationship with one of those folks or wants to reach out to them directly, they can make a request, an inquiry with them as well. A couple of their last remaining things are quarterly appearances at different community-based meetings, one of which would be the PCCEP, and then others as can be identified. And we're doing our best to do that. I've been coming to this meeting nearly every month since the beginning of last year-ish to be not, obviously I'm just but one person on the BHU Advisory Committee, but also a conduit of information for the BHU itself. Does that, and then as far as the BHU, we as officers and clinicians and our other support staff do find ways to engage the community and build better relationships with different providers and different locations. We will do coffee events back when we could do that. We'll go out to a location and maybe meet with some residents of a program and find different ways we engage in, like the NAMI walk and Lions for Life. And we just find different ways to partner and be accessible. And by all means, if folks have questions, they can reach out to me. We can always set up a time if you would like to meet with one of our teams, have coffee or brain as well as far as the work that they're doing. So I'm not sure if that answers your question or not.
So Amy, we're coming to you. We've got 4 minutes left. I did want to there were more in the chat after we finished it up. Zainab, who is one of our committee members for the PCCEP asked a very broad question about homelessness in Oregon. And so I think maybe that would be something we'd want to bring in some folks who are working on homelessness to have a conversation about.
Absolutely. Absolutely. Yeah. All of these topics are very intriguing to me to want to have conversations about. And next month, we're going to have a discussion, a further deeper dive in the ECIT program. So we really want to just have conversations and invite individuals to come and ask your questions. And then you can always email your questions to us at PCCEP, and we can get answers for you. We can answer them. You can come to our main meetings and get some questions answered. So we have lots of ways for public engagement, because Judith's right, we're winding down on time, and we also are working on recommendations. So we want to hear from everyone about what you think would be a good recommendation for this subcommittee to move forward with on whatever subject you're interested in. We're interested to hear from you. So I'm going to pass on my question, because I just want other folks to have a chance in whatever little time we have left.
Do you think, Amy, there's just enough time to thank the folks for coming? And
yeah, absolutely. We can, right now, good time. I had a wonderful time meeting everyone. Thank you, Billy. Your information was amazing. I really appreciate Casey. Yes, you're a charm. Thanks for being here, helping us understand. Sarah, I really appreciate you doing the work you do, because it's immense and intense. I'm down there, so I understand. And everyone else who participates in working with the mental health communities during COVID, I want to say be careful, wear your masks, and keep safe. So that we all keep safe. Those are my final words. Anybody else? Judith?
Thank you so much for coming. We really appreciate your participation. We hope you'll continue to come.
And they say the chat.
And our meetings are listed on PCCEP's website.
Did you save the chat, Claudia? Okay, cool. We have a lot of good stuff in there. Thanks, everybody. Have a good night. Stay safe.
Thank you, everyone.
Thank you all for
Wash
joining
your hands,
us.
wear a mask.
Thank you. Great turnout.